Now, as you heard, the first two speakers are actually relatively new to the project. Our next speaker, if you've attended any of our meetings for the last 5 years, I think, and seen some of the reports, and Patrick spoke about this, our next speaker will be no stranger to you. Dr. Hoganson was one of the first surgeons, I think it was 5 years ago, here in Boston, where he came and showed the experience of what he was doing, building virtual twins of children before actually providing the surgery. So doing the virtual surgery on the virtual twin, identifying the best surgery, and then performing it. And I still remember at the end, he was asked, so with all of the complexity that comes with your job, dealing with the family, the surgeries, why are you taking the time to understand the virtual twin and use it? And he answered very simply, I owe it to my patients to perform the best surgery possible. And now that I know what's possible, I have no other choice. And that stuck with me to this day. And with that, I'd like to invite up to the stage Dr. David Hoganson.
Great. Well, thank you, Steve. It's certainly a privilege to be here to share our experience. We've had a really fruitful collaboration with Dassault Systèmes, and it's enabled our focus on developing patient-centered and patient-specific modeling and simulation to use in the clinic to advance at a pace we had never dreamed would occur. So excited to share with you some of the work we're doing in modeling and simulation that's really focused on patients with really complex congenital heart disease. And so we have put together a team at Boston Children's Hospital to create three-dimensional models for patients with very complex congenital heart disease, and we do that through a process where we start with a CT scan or an MRI of a patient with complex heart disease, and then through a process called segmentation, we're able to create a patient-specific 3D model of that patient's heart. And then we've really used that as a platform to do many things, really in the same spirit of what's been done in the aerospace industry and the automotive industry, so getting away from the physical realm and staying totally in the digital realm. So we don't 3D print hearts anymore. We 3D printed more hearts than any program in the world, and then we completely stopped. And now we have a completely digital platform where we use these 3D digital models then as a basis for preoperative planning and intraoperative guidance. We also use them for computational reconstructive planning using virtual surgery and quantitative planning of patches and baffles. And then we also use simulation, including flow simulation with computational fluid dynamics, as well as mechanical simulation with finite element analysis, all in a patient-specific way to impact the decisions that we make before surgery and in surgery about how to care for these patients. And as Steve said, when we put this program together, we did so in a very non-traditional way. Even though I'm in academia, and the engineer who I run the team with, Pete Hammer, we're in academia, we decided to take a totally different approach. And rather than doing projects to sort of write papers and get grants, we made a totally patient-focused team and started this as a clinical consultation service. And out of that, we knew would come research and advancements, but it was totally about the patients from the very beginning. And then as we build a team to do this, we have a very busy pediatric cardiac surgery program at Boston Children's Hospital. We do about 1,400 operations a year, and there was absolutely no way to do this with postdocs and fellows and grad students. We really needed a professional team of engineers, and that had never been done before. So even when I told my chairman, I was like, I'm going to hire a bunch of engineers, he said, you're going to do what? But we did. So we have a phenomenal group of professional engineers, and this is their job, to make these models for these patients, to utilize these very advanced CAD tools to perform virtual surgery, flow simulation, finite element analysis. And so it's really been transformational for our heart center. And we're excited as this is, some of these techniques are starting to be used by other centers also. And so much like you heard that the living brain is being used in conferences, we use these 3D models every week in multiple conferences, and they're used as part of the communication with the other cardiologists and surgeons about the complexity of the heart disease that's being tackled, and as well as with the families. And we have, in the last 5 years, created almost 800 patient-specific clinical models that have been used in the clinical care of patients at Boston Children's Hospital. We did about 10 models our first year. We did almost 300 models last year, and I can only imagine what we're going to do this year. So it's really exploded. And a lot of those models have been focused on patients where the 3D model can be used for preoperative planning. So this is a patient with complex heart disease, and we create the 3D model with all the different structures having different parts. And so you can see the right atrium's in teal and the ventricle's in silver, the right ventricle's in purple and the left ventricle's in the peach color. And you can see the detail of these 3D models that we can achieve. This patient has multiple muscular ventricular septal defects or connections between the two ventricles. You can see there, looking from the right ventricle, 2 of those big holes that are going to need to be closed by the surgeon. But the bigger challenge is all the little holes that also exist that are also going to need to be closed. And you can see down there at the apex of the heart, more little holes, and then up by the pulmonary valve, additional holes. And you can imagine doing this with just echocardiographic guidance was a total nightmare in the past. And so now all of these patients get 3D models. These are used before surgery and in surgery. And so we use them as a tool for intraoperative guidance. We actually reprogrammed a Nintendo Switch controller, which we put in a sterile bag and is on the sterile field, so the surgeon has total control over the model. They can turn any component of the model on or off and get any cross-sectional view, external view, internal view with any combination of the anatomical features during the operation. And they're fully dimensioned, patient-specific models, so we can utilize that size and spacing information as we need. They've also been a basis for another innovation at Boston Children's Hospital, which is intraoperative conduction mapping. So for some of these very complex patients, there used to be about 40% incidence of injury to the conduction system or the electrical system during these complex reconstructions, requiring a pacemaker for life, which has over $1 million lifetime cost, as well as morbidity and sometimes early mortality. And so we've taken electrophysiology technology from the electrophysiology lab and actually using that in the operating room to identify where the conduction system is, and that gets mapped onto these 3D models. And now we have this library of over 120 patients who we've done this intraoperative mapping for and are understanding the location of this conduction system with more fidelity than we've ever had. When we started this effort, it wasn't to make 3D models that are only anatomic. The goal was to use the models as a basis for quantitative patch planning and computational fluid dynamics to really answer questions that there was no way to answer without these tools. And so this is a picture of our workflow for quantitative reconstructive planning. It starts with a 3D model, and then from the 3D model, we are able to plan patches that we're going to use in surgery, whether you're going to close a VSD or baffle a VSD to the aorta, or reconstruct an aortic arch or a pulmonary artery. And what that allows us to do is to come up with a patch that both has the size and the curvature that we need, but also is in the right physiologic state. The challenge with heart surgery is that when you operate either inside the heart or to reconstruct an aorta or pulmonary artery, everything is at zero pressure. It's flaccid. It's not the size and shape that you're really targeting. All you care about is what that patch does at in the physiologic state. So we're able to plan that in the right state and then back that patch out. And then, of course, most of our patch materials are flat, and most of these patches are curved. And so there's a non-obvious transformation that has to occur to go from a curved patch to a flat patch. So you get the same representation in 3D once that patch is pressurized. And so within 3D Experience, there's a phenomenal algorithm that was built for the aerospace industry that we're using in cardiac surgery to flatten those patches, and not only geometrically flatten them, but at the same time incorporate the mechanical properties of those patches All of our patches are stretchy. Sometimes they stretch twice as much in one direction as the other. That's incredibly important to incorporate into the patch design, and we're able to do that. We then installed another aerospace technology, and that's using lasers to project designs down onto parts. And so we have an aerospace laser that will project those designs, patch designs. I'll show you more about that later. And then, of course, we use it for intraoperative guidance. So this is a patient who has complex heart disease where the aorta comes off the right ventricle instead of the left ventricle, and there's a large communication between the two. It's called double outlet right ventricle. And you can see here the right ventricle is shown in purple, and the left ventricle is shown in orange in the background. And off the right ventricle comes both the pulmonary artery, shown in blue, as well as the aorta, shown there in red. And this is obviously a challenge. The left ventricle needs to send the blood to the aorta. And if you look here on the side, you can see there's a large ventricular septal defect or communication between those two ventricles. So a common challenge we have is how to redirect the blood flow from this VSD up to the aorta without blocking blood flow to the right ventricle outflow tract and without injury of the conduction system or the adjacent tricuspid valve. And so now we're able to take these 3D models of patient-specific hearts, bring them into 3D experience, design the patches to reconstruct the interventricular baffle, and then bring those patch materials back into the web-based viewer that we share the information with the clinicians. And so the clinicians are able to then pull this information up on their phone, on their computer, in the OR, and understand these patch material or patch size and shapes. And you can see we can turn off all the components of the 3D model and really back out what the patch looks like. And of course, this looks more like a Pringle than it does the flat patch that the surgeon's going to have in the OR. So then we have to do that transformation of how do we get the effectively curved shape into the flat patch that the surgeon's going to have to work with in the OR. And so then we can go through that flattening algorithm, dimension that, project that to the laser onto the sterile patch material, and then the surgeon has the precise solution in hand. And we've done this, and I've done this as a surgeon. I can tell you it's absolutely phenomenal to go in with a perfect plan as opposed to sort of making it up as you go, which is what we've done for decades. And this is a phenomenal step forward for us. One of the ways we're using this technology is to use computational fluid dynamics to really inform how we make decisions about the best therapy for really complex patients. And a group of these patients are collectively known as single ventricle patients, where they have such complexity of their heart disease that really they have one functional ventricle. And through a series of operations, we reconstruct their anatomy to achieve single ventricle physiology, where their one ventricle pumps blood to the body, and the blood passively drains to the lungs, and it's called the Fontan circulation. And because the blood doesn't have a pumping chamber to force it to the lungs, it's critical that all those connections and those pathways of how blood gets back to the lung is unobstructed and is so over a series of operations. And there's another important principle in that there's something that comes from the liver that needs to go to both lungs, and needs to go to both lungs in a somewhat balanced way. And if that yet undescribed, if anybody wants a Nobel Prize, yet undescribed liver factor, the hepatic factor, does not go to one lung, you develop abnormalities of that lung called pulmonary arterial venous malformations. And this is where the blood, rather than picking up oxygen or releasing carbon dioxide, it goes directly through the lung and does so with very low resistance. And this really derails the single ventricle circulation and is a big problem for these patients. And so the challenge comes in the fact that there's a lot of complex inputs of the flow returning to the lungs from the systemic veins. And if there's abnormalities in the systemic veins, and the surgeon historically has had to sort of guess at what connection options make the most sense for this patient to try to achieve that balance of hepatic venous return to both lungs. And it hasn't always gone well. And so this is a patient who's now a 21-year-old who has heterotaxia, which is a genetic abnormality that underlies many of our complex congenital heart disease defects. And they have complex single ventricle heart disease and some systemic venous abnormalities called interrupted inferior vena cava, where the blood from the lower body drains to the azygous vein rather than through the inferior vena cava. And this patient's had a series of surgeries, is a Fontan. You can see here the computational fluid dynamics show that the blood flow coming back from the different components of the liver goes up to the pulmonary arteries, shown here, the right pulmonary artery and the left pulmonary artery. These are the superior vena cava and innominate vein coming down from the upper body, and all the blood flow from the liver goes to the right lung. And so the left lung gets no blood flow and has developed these pulmonary arterial venous malformations, which have been treated in the cath lab, and the patient has declining oxygen levels, and really is on a course for not surviving much longer unless something is done. And so the question is, then what do you do? And without these tools, the surgeon's left to totally guess. And so we've been able to develop workflows to perform patient-specific modeling in these sort of situations. And this is the patient's current existing anatomy, where as you can see here, under normal physiology, 100% of the blood flow goes to the right lung. And after you eat, in the postprandial state, and when you exercise, it's still incredibly unbalanced. So this patient has a tremendous need to get that fixed. And so one of the common solutions has been to reconnect the veins from the liver to go directly back to this azygous vein, which comes up the back near the spine and then connects with the superior vena cava. And in many instances, this has been a good plan from the start. And this would have been a good plan for this patient from the start. As you can see here, under normal physiology, that gives 66% of the blood flow to the left lung from the liver and 34% to the right lung. You need about at least 20 or 25% to one lung to sort of stay safely out of the risk of developing arterial venous malformations. So this would have been a great plan for this patient had they had that 14 or 15 years ago when they had their Fontan operation. The challenge we have now is when you're trying to reverse those AVMs in these patients, what you really need to do is redirect almost all the hepatic venous flow to one lung and let those vessels heal from this sort of magic hepatic factor, and then ideally then rebalance that flow. But the challenge is these are very fragile patients, and so doing an operation on these patients is risky, and doing 2 operations on these patients is very risky. And so the question has been, how can we use these tools to rethink how we're going to treat this situation where the patients can probably tolerate 1 operation, but 2 operations would be a lot. But what we would ideally do is have this situation after we fix the left lung, right? And so with these virtual surgery tools, we're able to design patches now. So this is a patch that we designed that redirects all the blood flow from the upper body into the right lung and all the blood flow from the liver and the lower body into the left lung. And you can see this patch curves around in a complex curve shape, which now is not a big deal, and achieves that. And so, and then if you put a small hole in that patch, you do have some of the blood flow from the liver that goes to the right lung, but now 85% of that blood flow goes to the left lung. So now you've achieved what you'd like, is that almost all the blood flow from the liver goes to that left lung, and we can recover that lung. And then once that lung's arterial venous malformations are improved, we can use a catheter to then dilate that fenestration from 3 millimeters to 5 millimeters, and now we're back to 2/3 of the hepatic venous flow going to one lung and 1/3 to the other lung. So these are the opportunities that we have with this computational workflow, that there's no guessing involved, and we can design these operations and combinations of operations and interventional procedures to minimize the risk for these patients and know we're going to achieve very good outcome. And in the patients that we've done these flow studies on, we've done 100% follow-up MRIs, and so far we're within about 10% of our predicted values for blood flows to the lung. So this has been very accurate, and it gives us great confidence to do things like this, and this child will have an operation this summer. One of the other areas we've focused on is aortic arch reconstruction. This is a very common procedure we do for babies with complex heart disease, either in isolation or as part of another procedure. And this is a really complex 3D problem. So these patients are born with rather than a 7 or 8 millimeter aorta, they're born with a 2 or 3 millimeter aorta, and that aorta curves in 9 directions, or the patch to enlarge it has to curve in 9 directions. The aorta goes up and turns around your back and goes down near your spine. So this is a really complex and challenging problem, and the goal of surgeons is to not make the patch too small, and so they often make it too big, and that is another separate problem. So we've been working on a workflow with the help of Dassault Systèmes and their 3D Experience platform, and several of their outstanding engineers, including some of their aerospace engineers who had never done anything in the healthcare world, but we're excited to tackle these problems. And so we developed an all-digital workflow where we're able to design these complex 3D patches within 3D Experience. And so this is a common patient who has a normal-sized ascending aorta, a small, what we call transverse arch, where the head vessels come off, and then a very narrow portion called a coarctation, and then a normal-sized descending aorta. And what we do is we cut out the section of narrowing, and we pull the arch up together, and then we put a patch on the underside of the arch. And what we do now is we totally make this up as we go in the operating room. We open the aorta, and we take a big patch, and we start to sew it, and we trim as it goes, totally by the eyeball. We hope we get it right. And then we inflate the aorta, not knowing the orientation of the patch or the mechanical properties of that patch, which can stretch twice as much in one direction than the other at physiologic state. And you can imagine the variability that we have in the current workflow. And so we're excited to soon introduce this workflow where we come to the OR with a plan with a patch that knows the mechanical properties, knows the direction of stretch of that patch, and has flattened that patch so when it inflates into a curved shape, it'll be the right size and the shape, and we add margin. So as the sutures, as the surgeon sews it in, they know right where to put their sutures, so that doesn't additionally impact the patch. And this is going to be a huge step forward in repairing these patients. And we've done some validation studies on this laser we borrowed from the aerospace industry. And what we found is the absolute difference in length when you project the patch plan onto pericardium, which is a common patch material. Absolute difference of just over 1/4 millimeter in one direction and almost nothing in the other direction. So now we have a very, very high degree of precision, and we can transfer these digital plans onto the sterile patch material and into the patient, which is very exciting. And a recent development that I'm excited to share with you guys is the development of patient-specific mitral valve models for preoperative planning and intraoperative guidance. So with our nearly 800 structural models of the ventricles and the atria and the blood vessels, the piece that we've been missing is the AV valves. And this is a huge area of technical challenge for the field. We have one of the largest and most complex valve repair services for children on earth. And so we see a lot of these patients, and the goal has been to get our preoperative planning to the level that we're able to achieve with our structural planning. And so we have been lucky to recruit Dr. Rena Ghosh to our team, who's really spearheaded this creation of patient-specific mitral valve models. And this is a patient who has a structural model, as you can see, with a hugely dilated left atrium from chronic mitral valve disease. And what we're now able to do is create patient-specific models of the mitral valve, including the valvar or leaflet level of the valve, the subvalvular apparatus, including the cords as well as the papillary muscles. And all of those are components of these patients with complex congenital heart disease, and they often all need to be addressed. And so this is a picture of the detail of the papillary muscle shown in blue and the chordal architecture, as well as the leaflets shown in yellow and in light blue. And it gives us unprecedented information at an individual patient level to plan these operations. And you can see here the picture you get with the aortic valve annulus shown in purple, the mitral valve annulus shown in yellow, and the details of the leaflets. And obviously it doesn't, everyone in the room can tell where the problem is. You know, there's a lack of coaptation in those areas of the leaflets. And so this has really been transformational. We've now done 10 patients this way and have more in the pipeline. And what we're able to generate for the surgeons is a detailed 3D map in systole and in diastole, fully parameterized of all of the different aspects of the valve disease, including billow and prolapse and coaptation gaps, the distances of the chordal apparatus, and it's been really a remarkable step forward. And this is another patient that was recently cared for by our chairman, Dr. Del Nido. You can see some of the many specifics that we get from the segmented valve. And this is some intraoperative video. Thank you, Zach, for leading the way here. And you can see here, this is the complexity of this patient who did have an AV canal, which is sort of a 3-leaflet valve. And you can see here the hole in the superabridging leaflet that is exactly replicated in the operating room. And we found excellent congruence between what we're seeing in the valve model and what we're seeing in the operating room. This patient had a very complex repair after a prior repair in another institution, including an anterior patch. I don't know if you can play that video. It shows how we test valves in the operating room, which is to inject saline in it, and it has outstanding function by passive testing. Oh, maybe I skipped it. And this is a post-op echo showing that all the blood flow that goes through the mitral valve goes in the ventricle and virtually no blood goes back. So this is an outstanding result in a very complex patient, really enhanced by the use of these 3D models of patient-specific mitral valves. And I think you can probably already guess that based upon all the other work we do, we're excited about virtually adding in patches and cords and augmentation in a patient-specific way to go in the operating room, not with a hope, but with an exact plan to the 100 microns, 50 microns, and really, really change the paradigm of how valve surgery is being done, similar to what we're doing with some of these different areas. Takes a huge team to do this, and so we've built a team of engineers and scientists who are really a clinical team, and we do the most 3D modeling and simulation in the world by far, and for patient-specific use. So there's 14 of us now. We're adding another one in a couple months, and it's really been an amazing journey to put together the kind of service that can really impact these patients' lives. So thank you again for the opportunity to speak. It's been a joy to be here.
Well, once again, thank you, David, for demonstrating really where the industry is going. I mean, just every time I hear you talk about millimeter, sub-millimeter precision in surgery, my mind is blown, I have to say. So let me open up. I know you probably privately have a number of questions.
So proud to have this cooperation. It's a reveal each time we listen to you. Now, related to the tissue mechanic, do you do them on demand? Because as you mentioned, the elasticity in different directions are not the same. So do you use standard one and then you provide the orientation when you cut, or is there any other on-demand ways to produce these tissue mechanics?
Yeah, it's a real challenge, I'll be honest. So, interestingly, we've been doing this for decades with these patches and have never had this information. And so we're tackling it in a number of ways. There would be value in knowing the direction of the tissue alone. And so we're working with the two companies that provide those tissues to at least start by providing a direction. And we've tested many of these tissues in the lab. And so if we know the direction alone, we can use average data to start, which is way better than guessing. And we, to tackle this, have developed a mechanical tester that's sterilizable with the hopes to either test these patches as they're being prepared by the companies, like Artivion, who makes these from homograft tissue, or even in the operating room, so you can test both pericardium and other tissues. So I think at some point our level of precision with that piece will be as high as the other pieces, but it's been a real challenge because we're sort of fighting a paradigm that's really never been tackled.
Might have some ideas for it.
Yeah, I love it.
Okay, I think we have a question over here.
Dave, that was an awesome presentation. Your work in the congenital world is really amazing. Do you think, instead of the mitral valve, can we think about this type of modeling for a patient who undergoes a Ross procedure where we want to prevent them from being anticoagulated in the future and have a long duration, or an aortic valve repair, which sees a completely different pressure difference than the mitral valve?
Yeah, thank you, Alan. I didn't put it in here because we're about to publish it, but we've tackled that also. And so Pete Hammer, who I run the lab with, is a soft tissue biomechanics expert and has focused his whole career on valve biomechanics. And so we developed a workflow for aortic valves that's quite similar and involves creation of a 3D model. And we've been able to basically plan valve reconstructions, both for valve spraying roots, as well as like the inclusion Ross procedure, as well as aortic valve repair, which we do very commonly in children, less commonly done in adults. And so now we're doing those in a very, very quantified way. And so the surgeons are going in the operating room with an exact plan based upon the CT scan of the patient. We've done about 25 of those patients and have had outstanding outcomes. And so we're excited to share with the whole community exactly how we're doing that, but it's been a whole nother big project. Because you're right, it has all the same elements of the mitral valve work, and not only mitral valves, we're doing tricuspid valves also, as you can imagine. But for us, the complex AV canal patients are really, really challenging with straddling cords and all these features that before you're just sort of figuring out as you get in the operating room. We're able to do all that preoperatively now, which has been really transformational.
Great. Time for one more? Please.
I have a slightly different question about scale.
Yeah.
You said 800 models. There's probably hundreds of thousands, if not millions of people with heart conditions. What are your thoughts on scaling this kind of approach that you guys are doing to a wider audience across the country and maybe even around the world?
Yeah, it's a real challenge. So one of the answers to that has been virtually, not totally, but almost every other congenital program who does this uses clinical cardiologists to make the models sort of in their free time, which has never been a very good plan. And so we shifted all that to a professional team of engineers, which is part of how we've been able to scale locally. I think there's, in this early phase, basically everything is patient specific. But as we develop and learn and can quantify these into principles and rules, many patients of what we do, including, I suspect, the arch reconstructions for 90% of patients can be done with, a lot of patient-specific modeling done, and then, very little additional modeling required for that patient. And so I think there's going to be a simplification with very little loss for many of these patients. And another key step, which we haven't achieved as a community yet, is automatic segmentation. The longest piece of this right now is the manual segmentation. All the automatic segmentation you hear about applies nothing to congenital heart disease because of the complexity from patient to patient. So once that's achieved, that cuts out a huge piece of it. And then our team can focus on the virtual surgery and the simulation, which will always be a piece that's required by the engineering team. So there's a couple of steps to it, but it's a challenge for sure.
Thank you.
Yeah.
Great. Okay, I can't resist, but ask you one more question. So last time we met, I asked you the challenge about the patient experience.
Yeah.
And I'm not going to ask you that because we already have that. You want to hear?
I have some updates. We've made headway, but yeah, no, it's
okay.
It's a very important aspect as you and I both can personally attest to.
Yeah, but what I do want to ask, and maybe you can address this, or maybe we can do this afterwards, is related to the scale. Can you talk a little bit about the economics?
Yeah.
Right.
Yeah.
It's a big challenge in healthcare.
It's a big challenge. And it's been a huge portion of this effort for our group in particular. Is how do you take this from not a single center, because other centers are doing it, but everyone is doing it on the margin financially, and we've been able to make great strides with a very big team, but it's not easy to do that everywhere, right? And so how do we take this from this level of effort to a nationally recognized and reimbursed effort? And I think that's an enormously important step. The regulatory piece, which we're going to talk a lot about tomorrow, is an enormously important piece, but the reimbursement piece is also enormously important. The reason that cardiac MRI is in every hospital in the nation is because it's paid for, and it's paid for well. And this is an equally expensive therapy, and it just needs to be reimbursed. And so we're well down that path. I can tell you we've been billing this year, and we've been reimbursed for these models at Boston Children's. Some very exciting progress in that area, and so getting that to the national level where we have CPT codes is the next step. but I think that's going to be as important as all the technical piece is the regulatory and the reimbursement piece to make sure this is a durable therapy that everybody can have access to, not just at a few centers.
Great, fantastic. Well, just have to say, and I'm sure everyone's thinking, in the field of healthcare, what you've achieved in 5 or 6 years is tremendous. It's changing lives, it's changing the whole industry. And with that, let's give us another round of applause for his team.